Okay, class. In this last part of the lecture, we'll get into blood pressure screening and PT practice and kind of integrating this all together, right? So we've talked about how common blood pressure and other cardiometabolic risk factors are in PT practice. We talked about exercise responses. We talked about why we can't really just rely on a medical history, right? One, because even a patient has been medicated, right? They've been diagnosed and prescribed, which isn't even a guarantee to get to that point. It's not even a guarantee that they're controlled. It's a 50% odds they aren't. So, there's a really, I think, role for us in screening and potentially managing, as we talked about, the ability for us to routinely assess exercise responses in clinic, because there's no other place in healthcare that people routinely move and exercise, right? Other than the PT clinic. You're in your medical office, you're sitting in a chair, or at an exam table. You're not moving around. You can't see those exercise responses. And then we can bill for therapeutic exercise. So I think there's a role for us in this going forward. And it starts with, though, screening and making this part of our professional identity and taking these risk factors seriously. Because we take cancer very seriously, we take other conditions very seriously. Yet something that we see incredibly often, the screening behaviors just aren't where they need to be. Hopefully that changes. So the first conversation that we'll have is just about pain, right? So a question I often get is like, what about pain? Isn't that going to throw off my readings? My patients are coming into my clinic, right? Isn't that going to all automatically make their values invalid or inflate their blood pressure readings? So I do want to stress that acute pain has been shown to increase heart rate and blood pressure in experimental models, right? So this would be cold pressor test, right? Or pressure to the skin or nail beds, electrical stimulation. In the cold pressor test, basically we put people's hands in an ice bucket and we watch to see how long they can sustain that, and we look at their blood pressure and heart rate responses. Now, obviously this is a little bit different than real world clinical settings, right? Because if you think about it, these experiments are really looking at a nociceptive sensory input, right? Any sensory input is going to cause a sympathetic or an autonomic response. So it's a little bit different, right? And pain is not just sensory input output. It's a processing experience, right? It's a little bit more complex. And remembering that illness, fever, medication, anxiety may all obscure the relationship between pain intensity and hemodynamics, right? And anxiety, right? If you're in acute, clinical pain, like we're seeing in the clinic, that also causes heart rate to increase. So it's not a one-to-one relationship in the clinical setting. And again, remembering with these experimental trials, we're introducing a novel, noxious stimulus and looking at autonomic responses, which we would expect to happen, right? So, just here's some examples of what we're talking about. Like we do see, in these experimental studies, systolic blood pressure does increase with experimental pain, right? So this cold pressor test. Again, we're submerging people's hands, right, in an ice bucket. Like that's gonna cause an autonomic response, right? That's gonna happen. And then we see the same things with diastolic blood pressure. But even within that, like the majority of patients in this study by Zhao, showed that you're not seeing 40-point increases in blood pressure, right? So someone's walking into your clinic and their blood pressure is 150. That clinical pain they're experiencing probably isn't moving them from 110 to 150, right? On average, maybe we'll see like a 10-tick increase, right? We're not seeing huge changes just from pain. And actually, I'll show you some data in a bit that shows that it might not change much at all, actually. And we'll get into that. So again, this is what we see as well when we do these cold pressure tests. Again, there's going to be a spike, and after it'll eventually resolve, especially in recovery. Once they remove the hands in these trials. Now, I do want to stress that again, these are experimental studies. It's a little bit different than clinical pain. Now, heart rate, same thing. Increases concomitantly with exposures to noxious stimuli. But again, it's not a wholesale change. Maybe a 9 beat per minute increase, right? It is associated with higher pain levels, again, in an experimental study. However, in women, actually, the women with the largest heart rate increase didn't necessarily report more pain. And on average, women actually reported less pain, which is interesting in and of itself. When we look at maternal responses and stuff like that, the ability for women, the pain tolerance women they had actually maybe a little bit higher than men. So again, same thing, experimental studies, we're going to see that sharp increase, but we're not seeing people move from 75 to 120 heart rate. Like, it's not really what happens. On average, we're looking at maybe an increase of about 7% from baseline, right? And again, as we remember, heart rate alone should never really be a guide to make you think someone's in pain or not, because like we mentioned, in that even in the experimental study in women, women with the highest heart rate response didn't necessarily report the most pain. So it's, again, heart rate responses to anything, it's just responding to a stimulus, right? We're shocking the system a little bit. Now, where things get a little bit murkier when we look at clinical pain, patients coming into an emergency room with pain. So BOSAR, and most of this is from an emergency room. So again, it's observational, right? There's always going to be some other extraneous factors limited, but like this is one of the few, these are the studies that we have available about what actually is out there, in terms of real world clinical pain. So BOSAR et al. Recruited 900 or data from 975 emergency room patients over a 4-month period, average age 36, average pain duration was 33 hours. So that's actually patients a little bit more acute than we typically see in a PT clinic, right? I mean, we're very rarely are we seeing patients right as they hurt themselves, unfortunately. So the outcomes they tracked were mean heart rate, mean pain intensity at the time of triage, after receiving analgesia, and at the time of discharge. Their results were mean pain intensity and heart rate did decrease over the course of the stay. However, there was no correlation between the changes in heart rate and the changes in pain intensity. So again, experimental pain, right, is a response to a noxious stimulus. But you can have a response from any stimulus. If you rub your hand on someone's skin, it's going to cause a change in heart rate. It's an autonomic response. Clinical pain is not sensory input-output. It's a processing thing. It's a little bit different. So again, we see very, very little association. Remember, Pearson-Rowe is a correlation between the strength of two values. 0 means no correlation. 1 means very strong correlation. And this was 0.8, no correlation. Dayob et al. Looked at the National Hospital Ambulatory Medical Care Survey. So those 10,000 ED visits. 80% of the visits were from, the participants were from white patients. Majority of them were musculoskeletal or traumatic conditions. So we're talking about fractures, sprains, strains, dislocations, open wound, a crush injury. The outcomes they tracked were vitals. And again, self-reported pain scale on an average, 1 to 10, 10 being the worst. It's a triage, pretty common, right? So the results they found, adjusted heart rate, self-reported pain score of 1 was 80, about 85, right? And this was a confidence interval here. The adjusted heart rate for self-reported pain of 10 was 88 beats per minute. So it went up, a small increase, but with only small positive association between self-reported pain, and there was no association among Black patients. So again, even amongst different demographics, there was no association, or very limited association. And again, while the confidence intervals were above, these, they didn't overlap, we're talking about a 3 beat per minute increase, not substantial. Not enough to make the readings you take at baseline to be invalidated. And if we look at blood pressure, now Marco et al. Looked at retrospectively, analyzed data from 1,000 emergency room departments. Again, this is all observational data, right? There's other things, Simpson's paradox, that can, contribute to what we're observing here. It's observational data. It's not an experimental study. But the group averaged 41 years of age, which is pretty similar to what we're seeing in PT practice. Average pain rating is 7 out of 10, so pretty severe. The range was between 3 and 8. Heart rate, 85 the baseline. Respiratory rate of 19, systolic blood pressure 141. Outcomes they track were pain, heart rate, respiratory rate, and systolic blood pressure. Remember that Pearson's R? For heart rate, 0.8, nothing. Respiratory rate, 0.4, and actually trending negative, which is suggesting that very weak association, and the association actually suggests that pain went up, respiratory rate actually went down a little bit, but no association. And systolic blood pressure was 0.04, also next to nothing. So there was no clinically significant association between self-reported triage pain scores and heart rate, blood pressure, or respiratory rate. And again, here's the raw data, looking at what we're seeing. So again, a patient with 0, and these are patients, again, in the emergency room, like with pain, like with issues here. So patients with 0, average heart rate of 81, blood pressure of 143, respiratory rate of 19. People with 10, heart rate of 86. So it went up, but not a wholesale change. Systolic blood pressure was 140 on average. And if we look at, even if we go from 0, right, patients with a 1 out of 10 had a higher rating than patients with than a 10 out of 10. Almost no change in respiratory rate, but I'll even say most people don't actually measure respiratory rate. But again, it paints a picture. Clinical pain's a little bit different than experimental pain. And here's the, looking at the actual raw plot. So again, what this suggests is we cannot invalidate someone's experience of pain because they don't have a concomitant increase in heart rate or blood pressure. Pain is way more complex than that. If someone tells you they're in 10 out of 10 pain, you believe them, right? You don't invalidate their experience, right? Maybe you educate and we work through things, but don't base it just off a single data point because the evidence doesn't really suggest that that's super valid, right? And while there is experimental pain that's going to cause those acute responses, that's an experiment, right? We're introducing a stimulus to our body. We're going to have a concomitant autonomic response, kind of how it works. So again, this is just plotting, again, looking at blood pressure. They all overlap. Same thing for heart rate. No correlation, not much change, and they stay pretty level. Now, granted, chronic pain, that's where things get a little bit more interesting. And chronic pain, a lot of things kind of get a little bit smudged in terms of the clarity of what we're looking at in terms of the physiology. Now, in patients with chronic pain, we typically see a higher prevalence of hypertension, higher heart rates at rest, because we think there's often this shift in sympathovagal balance. However, their blood pressure response tends to be a little bit attenuated. And we think that may be due to, if you're chronically in pain, maybe there's this changes in sympathetic nervous system reactivity, that it just doesn't, it's always elevated. So the responses are just going to be a little bit attenuated. But again, thinking of, broadly here, again, patients with chronic pain, 1.5 times more likely to have cardiovascular disease than those without it. We talked about this at the very beginning. And chronic pain, right, there's contributors to this. Physical inactivity, poor sleep, anxiety, which are all gonna feed into maybe some cardiometabolic risk factors, right? So, chronic pain, things get a little bit more murky, but I think some underlying contributors to chronic pain, and there's evidence to support this as well, is cardiometabolic disease, right? If you're active, if you're healthy, if you're eating better, if you're sleeping better, which also improves blood pressure, improves your pain as well. So there really is a major role for us here as a profession to intercede, because these are the same patients that we're seeing. Patients with chronic pain often have cardiometabolic issues, even patients with acute pain. Patients with, osteoarthritis, low back pain, have these cardiometabolic risk factors. Blood pressure is a big one. And we can improve both things with what we do, right? Our bodies don't operate in silos, and neither do our patients. So often what improves one thing will often improve the other, and often what is a detriment to one part of our our pain experience may be to the detriment of our cardiometabolic health. Something to think about. So some things I want to touch on as well. Vertebral artery tests, we'll learn about this. The sensitivity and reliability of this isn't super great. Again, there's different changes to, when we rotate the head in one direction, we may be occluding one artery versus the other. Roger Carey, said it's not possible to provide a definitive answer, to whether or not someone is at risk for an acute event from a vertebral artery test. And he actually recommends that we should really be looking at risk factors more than just this single test, which has very poor reliability. What's the health of their vascular system? Are they hypertensive? Do they smoke? Do they have do they have diabetes, obesity? And factoring all these things in together, looking at our pain patterns, you'll learn more about this musculoskeletal. Most of the time, vertebral arteries, in terms of these stroke events we see with manipulations, that usually was someone who had damage to a cervical artery that wasn't screened, and then it wasn't so much the manipulation as that you missed it and they were in your clinic and an event happened. So doing your screening and a thorough medical diagnosis, including taking blood pressure, is a big part of it, and you probably will be a little bit more successful than just relying on a vertebral artery test, which isn't going to really tell you too much. Roger Carey is a guy I would strongly recommend following. And IFOMPT even recommends this, that we should be really looking at risk factors about whether or not someone is at risk. Because honestly, there's been some reports that even patient placing a position in the position for the vertebral artery test may actually be more strenuous on the cervical arteries than a translatory manipulation, right? So maybe we should be looking at these other factors because maybe the vertebral artery test is actually a higher risk event. So given all this, what is a screening behavior from PTs? Well, this is some data from Ethel Fries in 2002, a landmark study which found that despite the fact that many PTs consider measuring blood pressure to be important, they very infrequently screened. She found that heart rate was measured always 4%. Blood pressure was 4%. Heart rate was 6%. Right, and then our follow-up study. So they looked at CIs, a sample of about 387. We had a sample of about 1,800. So this won the Dorothy Briggs Scientific Memorial Award. It's a pretty important study. So we found that numbers went up a little bit, which is good. However, if we looked at the breakdown, close to 15% never measured, and it's about equal, right, for those who always measured. And the vast majority were in the 0 to 25%. So not that they never did it, but they very infrequently did it. And then we asked in our survey, well, what were the reasons why you screened, right? So if we looked at why people screened, they felt it was important. They had a clinic policy. And for those who didn't, it was almost the same, but just reciprocal. They did not think it was important. They didn't have a clinic policy, and they didn't have time. They felt they didn't have time. So again, we think that perhaps it's changing the perception, because as we have seen, this is clearly important. And hopefully by the end of this lecture, you guys are like, yeah, I have to screen. I'm going to see this stuff often. So a lot of it's just educating people and saying, hey, like we need to be screening because we're going to be seeing this often. And we actually found in our study that quite often PTs who practiced in more or clinics with older populations and individuals who had higher risk burdens, they were, I think, like 19 times more likely to screen, or very much more likely to screen. So again, if you see this every day, or at least if you're aware, because maybe these people just weren't aware that how often the risk burden, despite the sample said most people knew they were aware, but realizing how important it is, because it only takes one case going awry for things to go really, really bad for you. The question I ask, is it plausible? Well, the example from Dentistry There's a study in Sweden, so again, European model, but analogous model, because we're seeing this used in the United States as well, where they screen patients without known diagnosis of hypertension who were between 20 and 39 with a BMI, greater than 25. So people, known diagnosis of hypertension. They had a total of about 1,100 people included. Mean age was 46. Mean weight was about 79 kilograms, mean BMI. So a little bit leaner than we see in the US population, but generally these are people with no known hypertension. What they found was, of the patients they screened, and they used a cutoff, I believe, of 160 over 90, right? So they only were taking patients, right, who screened at a little bit higher, right? So people on this criteria, this farther end. They found that 20% of those who screened positive are on their testing. And the way they did it is, if you had a high test, they would wait 5 minutes and they would retest again, and they would take the lower number out of those two tests. They found that 1/3 of those patients who screened positive, right? Again, they use a very, very, very restrictive cutoff, like 160 is far into hypertension. It's not even a borderline thing. You're in the 160, you probably have hypertension. They found that 1/3 of those who received a diagnosis of hypertension within 3 years. The screening and sensitivity was 79%, specificity was 30%, and the number needed to screen to get someone who was positive and then eventually diagnosed was 18, right? So this demonstrates that, again, there can be criteria put into place that can help us detect these patients, get them into a medical system and managed. So again, number needed to treat was 18. And then again, after about a period of 3 years, right, 1/3 of those patients ended up getting testing screening positive. So again, if we look at when these plots here, the number of people ended up having a positive diagnosis. So my recommendations for you guys, right? Anyone above 190, you can proceed with usual care. Just going to contact the PCP. 160 over 100, hold resistance exercise. Probably gonna monitor closely. There's most things you can do, and you only really hold care. You don't do anything. You're assessing. It's when someone's in a crisis, and that is what you would do consistent across the literature in medicine. Someone's in a hypertensive crisis, let's screen for end organ damage, making sure they're not in an emergency where they need to be emergently have their blood pressure lowered. If they're just in an urgency, then we're just going to contact the PCP. Maybe they need to adjust their medications. Could go to an urgent care. It's not a 911 call. We've got a great paper was published in PTJ, which took this image from my colleague Sarah Arena that uses her recommendations here, and again, very similar to ours that we highlighted here. So again, this was based off of the older blood pressure guidelines, so that's why it's 110. You could even use 120 if you wanted to be more consistent with the 2017 guidelines. So this is a great template. This has been very, very well received because we found that people who just didn't have a policy, didn't know what to do, avoided screening. Now I'd say that there are several approaches to blood pressure screening by PTs. You could take it as a PT, right? There's multiple different options you can use for devices. You can set up a blood pressure station, right? Maybe you're a one-man show. You don't have support staff to take it, like a tech. So you could set up a blood pressure station. I do it from a telehealth standpoint, and my patients monitor theirs at home. There's ways to do that from a telehealth standpoint. And in terms of benefits, right, like the PT, obviously you benefit because you're kind of covering your license, but just better healthcare, right? It's better for our healthcare system because we can identify patients earlier on and get them managed. We talked about 10% improvement in treatment. This can save 14,000 lives. And we're uniquely positioned because we're already seeing these patients in abundance. The data is overwhelming, and it's a way for us to prescribe exercise more appropriately and safely. And again, talking about our unique situation within healthcare, or where we're uniquely situated in terms of being able to assess these exercise responses and potentially maybe intervene if we identify maybe someone has post-exercise hypotension who would do well with an exercise program. That could be great for our profession. There's a large, obviously hypertension is a problem. The American College of Cardiology, the AHA, medicine in general is calling out saying, hey, we are trying to move patients up, to get them medicalized so they can be managed, but we don't really have options for exercise training for these types of patients. These aren't patients that need to be in cardiac rehab, just with hypertension and maybe some risk factors. Maybe they could be seen by a PT. Maybe you could be the PT that helps lead this charge. So some final thoughts. Again, many patients are unaware of their diagnosis or their disease status. They lack control, lack compliance. We need to be screening early. The consensus is clear. And most of these patients have, have an access to the healthcare system. We have, and our survey data supports this, that we have the skills, you have the training. We need to take this on every new patient and then start considering adding this on into our, what we do during exercise, looking at acute responses. And I'll leave you with one story here before we end. So reasons to monitor vital signs. So you may notice on the left, this tall, or I guess moderately tall, strapping young man with sans beard. Well, that's actually me. This is me in 2009, graduating from Penn State. On the right there is my mother. So my mother actually, typically has very low blood pressure, very well controlled. However, she worked in, she works as an autistic support. And one day she ended up getting standing concussion. They were in gym class, working with the kids, and ended up getting a concussion. So she goes to see a PT, right? My mom sees her primary care doctor, routinely. Well, she's working with the PT, and her concussion symptoms are getting better, but she's still having this residual, this kind of lightheadedness and dizziness, and wasn't really sure. Well, the PT there thought, like, hey, let me check her blood pressure, right? Her blood pressure, took her heart rate. Notice her blood pressure was a little bit funky, a little bit elevated, a little strange, and she was missing a beat every couple of seconds. Sent her to her primary care with these findings. Primary care, sent her for an ECG, sent her to a cardiologist. Turns out my mom was losing about 20% of her ejection fraction. She had an arrhythmia that went undetected, and the arrhythmia was due to having hypertension. PT saved my mom's life. And this is just one example of countless stories that I've heard since we started this campaign and this push to really get blood pressure screening. And again, all it takes is one missed vital to have a disastrous consequence. And all it takes is one caught abnormal vital sign to be a hero. So be a hero. Vitals are vital. And I hope you guys enjoyed this lecture. Thank you.